up. You were with us from the very beginning, and really appreciate all the help that you've had, that you've given us as we've put this consortium together. And so thank you very much, and look forward to all the things that you are going to be doing next, or not, relaxing.
All right, thank you. I'd like to introduce Dr. Nikisha Oliphant, who will be taking my place. She'll be working with Dr. Farmer. It has been a pleasure working with this team. We've had some changes, but it is now my turn to make the change. Steve, you changed but came back and stayed on. I'm not sure I'm going to do that, but maybe in the future. But right now, I just want to have no plans. I want to make no plans. I don't want to produce any plans. I don't want to follow any plans. I just want to be me for a while. All right, you guys, thank you.
Very good. Very good. Congrats. Enjoy retirement.
Very good, Alan. So as we begin. Okay, let me try it again. Sorry, we got some feedback in this room. Can you hear me okay now? Okay. So as we begin, just a reminder, especially for the new members of the consortium, since this is a public meeting, we can't use the chat function. If you put something in the chat function in order to be compliant with the Open Meetings Act, I have to read that out loud, and you don't want me to read out loud every comment. And so let's refrain from the chat function. And again, if you have something to say, please raise your hand. Use the hand raising icon, and look forward to the conversation today. We have several important things that we need to discuss today as we move forward. But the first thing we need to do is officially approve the minutes from the last meeting. So take a few moments here and take a look at those minutes. And once one of you feel comfortable, please make a motion to approve, and then we'll move forward in the meeting.
Move to approve.
Second.
All right, Alan, second.
Second.
I think it was Dr. Wagner. Did you second that? Very good. Any further discussion? Hearing none, all in favor of approving the minutes from the last meeting, signify by saying aye.
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 Opposed, nay. Hearing none, we're moving forward. Okay, Scott Shacklin has joined. Thanks, Scott. And anybody else joined since we took the roll call? All right, hearing none, let's move forward. The first topic of conversation today will be on TChat. We have several updates and a couple of policies that we want to review with you today. The vote for the policies will be at the next meeting, but I will turn this portion of the meeting over to Rachel Chu.
Thank you, Dr. Lakey. First, I'll start with our regular presentation on statewide expansion. So as of March 31st, we are active in 68% of schools. That represents 72% of the student population. 9 HRIs this month added at least one school district. We also have a number of HRIs, 4 HRIs with schools in an onboarding status with a date for onboarding. So you can see quite a few schools coming on board in the next few months. Taking a look by ESC, we saw growth in 10 ESCs this month. ESCs 1, 2, 4, 7, 8, 10, 11, 12, 13, and 20. And here you can see growth continues to look very good. And we hope to see that continuing. Reasons for decline, this hasn't changed. So, for most schools that decline, they do have existing mental health services. And then other schools do other districts choose to onboard only a select number of schools within their district. Any questions on statewide expansion?
I guess one comment, Rachel, again, thanks for putting all this together. We we're having the budget meetings right now with each of the HRIs. And one of the things that comes up is predicting for the next year, for the next biennium. We have a lot of schools that we've reached out to multiple times and haven't received a response. And so we're going to need to make a decision come August on whether we need to secure the resources for them in the next biennium or not. And so if there are large school districts or other school districts that have not responded, I think it's time to talk to them and say, we need to answer. And if any school district that wants to be in, we want to bring them in, but we also want to make sure that we get the resources appropriately to do that. And so there'll be a little bit of that cleanup of this chart as we reach out to those institutions and make sure they understand that we need an answer. And so that we kind of move from this phase of the statewide rollout into a phase of quality improvement. Again, understanding that if there are other schools that want to come in, we want to work with them, but we need to have some predictability there as we try to gather the resources we need during the next session. Rachel, anything on that you want to say?
We have asked all of our HRIs to make kind of like a final outreach attempt to these 684 planned schools remaining. And we really hope to see, as Dr. Leakey mentioned, by the end of the fiscal year, those campuses, move to hopefully a pending status, but also, if needed, a declined or unresponsive status as well.
Any questions on?
This is Sue Shell in Dallas. We're making outreach again to all the districts, and especially those that have only added limited campuses, particularly our biggest one, Dallas ISD. And one thing to keep in mind as people make these additional outreaches is that some of them have benefited from ARPA funds that are going to be ending and changing. So we're hoping that may bring them a little more interested in the T-Chat service when they lose that funding.
I think that's a good point, Sue. There are several school districts, some of the larger school districts that have been benefited from those ARPA funds, but with them going away, we'll be looking for additional mental health services. And that's why it's important to talk to the schools and reach out. And but as we build the budget and go to the legislature, we need to have pretty good, solid numbers related to the number of districts and schools so that what the resources you need and the number of personnel that you need during the biennium. Okay. Any other questions or comments? Hearing none, Rachel, you want to move on to the summit?
Sure. Just want to provide a quick update that our T-Chat Leadership Summit is scheduled for next month, June 27th and 28th here in Austin at the JJ Pickle campus. We have over 120 registrants as of last week, but we do have some spots still available if any folks from our HRIs would like to attend. We just ask that supervisor approval be obtained before that. But we're really looking forward to convening all of our HRIs together. And this year we'll be focusing a lot on T-Chat 2.0. And, as Dr. Leakey mentioned, kind of moving out of that implementation phase and then focusing more on quality improvement and process improvement.
Okay. Any questions? All right, very good. The next item, we have a couple of policies that we want to review with you today. We're not voting on these policies. We were trying to make sure in one executive committee, we review the policies, let you have a chance to think through them, figure out if there's any nuances or any things that need to be adjusted, and then give us that feedback. And then at our next meeting, we'll be trying to approve those policies. Again, part of the process here is putting these things down on paper to make sure that there's clear understanding of how we're trying to administer the various programs of the Texas Child Mental Health Care Consortium. And so there's two that we're going to discuss today, one related to fingerprinting and one related to school outreach and enrollment policy. And I'll let Rachel walk through both of those.
So I'll touch on fingerprint-based background checks first. We heard from half of our HRIs that they are experiencing issues related to meeting requirements for a fingerprint-based background checks. So state law through Texas Education Code does require fingerprint-based background checks for contractors working with students. So anyone with direct ongoing contact with a student has to undergo this fingerprint-based background check. After a set of fingerprints has been submitted, every ISD should have access to the criminal history tied to those fingerprints. We have heard from our HRIs, though, that they have been asked to provide additional sets of fingerprints. We think this is probably due to maybe one or two issues. One, after the first 30-day period, when the fingerprints become available in the state's criminal history database, there is a $1 fee to view those results. So some ISDs may choose to request that the employee submit another set of fingerprints that's at a cost of $38.25 instead of the district paying that $1 fee to view. We also know that ISDs can maintain their own local level requirements. And those requirements may involve submitting another set of fingerprints. And in conducting some research, we also identified a second issue that not all of our institutions are requiring fingerprints for a criminal history background check for all staff who do have direct ongoing contact with students. So we know that some of our staff are fingerprinted for credentialing, and those fingerprint-based criminal history may be checked regularly for some, but not all of our staff. Additionally, the results of the fingerprint-based background checks that go to the ISDs are not shared with HRIs. So that does present some risk to us, and we want to make sure that we can mitigate that risk of employing staff with questionable criminal histories as quickly and directly as possible. So we have 4 recommendations to address these issues. Our first one is to reduce the likelihood of duplicative fingerprinting by applying for NCPA contractor status. I'll get into that in a minute. This recommendation, if you all approve it, will not be required for HRIs, but we do think that there are a number of benefits to applying as an NCPA contractor. Including these that I've listed here. First, HRIs will have direct access to fingerprint-based criminal history results. Again, making sure that we can directly and very quickly, address any issues with criminal history of our employees. Fingerprint-based background checks are also more accurate than just a name-based check. There is no cost to apply as an NCPA qualified school contractor, and the application process is pretty quick. In discussions with DPS, they've told me that it takes about 14 days. This also includes notification of new criminal history after the initial and after the fingerprints have been initially submitted and that initial check has been done. This is called wrap back results. So HRIs, if they apply for contractor status and have access to the database, they will be notified as soon as new criminal history has been recorded. I mentioned there's no cost to view initial results within 30 days, and there is a $1 fee to view results after that initial 30-day period. We do think, however, that this would be cost effective for our HRIs, especially those that have experienced significant issues with needing to fingerprint their staff multiple times. Again, it's $38.25 each time a set of prints is submitted. We feel like this is a very cost-effective option. Certification also takes the burden off of districts and schools. So let me get into what it means to be an NCPA qualified school contractor. So NCPA is a National Child Protection Act. Under the National Child Protection Act, a contractor can be deemed a qualified school contractor by the Department of Public Safety. And that will enable the contractor, the HRI or HRI subcontractor, to have access to the state's database of fingerprint-based criminal history. So NCPA contractors will submit employee information through the clearinghouse and review those criminal history results and certify those results to the district and school. So this means that the ISD does not need to order fingerprints for that employee because the employee has already submitted fingerprints through the HRI. And then the HRI will certify that they are in compliance with state law. Our second recommendation is to add language to specific documents to ensure that background checks are in compliance with state law and local requirements. So if the EC approves this recommendation, we will be amending our PIAs with all of our HRIs to include requirements for meeting these state and local requirements. HRIs may amend MOUs with ISDs just to ensure that any agreed upon methods for meeting these requirements are met. This won't be required, but again, we feel, for the HRIs, especially that are experiencing these issues, we feel like this is something that they should consider. HRIs can also consider adding language in printed materials for districts and schools about what those expectations are and how the HRI intends to meet those requirements. Our third recommendation is to maintain fingerprint-based background checks for staff with direct ongoing contact with students. So we will be requiring this recommendation if you all approve it. And that will be for all HRIs and subcontracted partners with staff with direct ongoing contact with students. These requirements include HRIs should ensure that every TCHAT employee with direct ongoing contact undergoes a fingerprint-based background check with results that are accessible to the institution. Again, we know that many of our staff go through the credentialing process in their institution. That can meet the need as long as that covers all staff with direct ongoing contact with students. Again, alternatively, you all may consider applying for NCPA contractor status. We're asking that criminal histories be checked at least every 3 years by each institution. And then for any non-credentialed staff who are not fingerprinted, we are asking that a clinician who has undergone a fingerprint-based background check join those staff when engaging with students. Our final recommendation here is to adopt a policy just to define these expectations for fingerprint-based background checks. You all have a copy of the policy. This is just a quick summary of what we're proposing. HRIs are required to coordinate with districts to ensure that any background check requirements are met. They're also required to ensure that that initial and regular fingerprint-based background check is completed for any employees with direct ongoing contact with students. And we want to make sure that those results are accessible to the institution. We're also in policy noting that HRIs are responsible for covering the cost of fingerprinting for employees. Again, that's $38.25 for each set of prints. This can be done through reimbursement or direct pay. And then finally, HRIs are responsible for ensuring PIA requirements are met. So here's our timeline. After the issue was identified, we did some research to prepare these recommendations. Then we obtained feedback from Kosh and from TChat leaders. Today we're introducing this to you so that next month we can hopefully facilitate a vote from you all. In the time between now and then, we welcome your questions, comments, concerns before we implement the policy. Some of our HRIs have noted that this may take some time for them to implement. So we want to work with every HRI to make sure that an implementation date works for them. And Kosh will be available to provide that implementation support. What questions do we have? Dr. Wakefield, I see your hand is raised.
Yes, my question is more of a theoretical question for maybe Sushel, TEA, when we're thinking about what are I guess I haven't really considered us as a contractor with the school, that our MOUs with schools are more giving us space and referral line, but that we're doing a direct like clinic with patients and families. And so I was just interested in what defines, because I think of that when I read the statute as those individuals who might be helping the school or doing something without parental consent, and are really an extension of the school, which I just conceptually feel like we're different than that. So wanted to have that conversation.
I think that's a great point. Yeah, we've even before TChat, we always had an MOU, and as you say, we're getting consent just like we do if we treat a child in person in one of our routine hospital programs. So I think it's a great point. And off the top of my head, I don't know if we do fingerprint background checks on people. I know we do background checks and drug tests, but I'll have to look into that to see if we meet this standard.
Is there any, I mean, yeah, I guess that's just a bigger theoretical question. Because I wonder if we're applying this statute, if it's applicable to us in the first place.
Yeah, the MOUs are contracts, so if that's all that the NPCA requires, then I don't really think that should provide an obstacle. We can certainly take a closer look at the statute, but my instinct is that shouldn't stand in the way.
I do think, Dr. Wakefield, that some of our HRIs have had this experience with districts where because of the MOU, that kind of initiates this discussion about fingerprint-based background checks.
Yeah, we've had it with one in particular, and we went ahead and did the fingerprints for the one that required that, and worked with our legal team to do it. It is additional, it does provide an additional cumbersome kind of obstacle for that. But I was just interested because we're contracted with we have MOUs. I think some of this language, I guess that's my actual question is we use of course, MOU is a contract. And so does that then mean we fall under the statute? Because typically I think of this as somewhat different than what the statute is trying to regulate. So just wanted maybe David or TEA just kind of think through that, because there might be other things that we're opening ourselves up to if we are thinking of ourselves in that capacity, instead of the MOU is allowing us to have space at that clinic and a referral process, but we're really seeing those families and patients independently.
I think we're happy to go back. I guess in one of our meetings beforehand, our folks had language that made it look really like that we were our contractors, whether we liked it or not. But I'm happy to go and double check that to make sure that we're reading that correctly.
Well,
and again, this is part of a process of this was brought to us in several forms and trying to get the feedback from the institutions to make sure we get the policy right.
And I'm thinking it's really important that we have the clarification for schools too. Again, I'm not suggesting one thing or the other, but just to like really clarifying, do we fall into this category? And if we do, then what else would might that mean for us? Because when I read it, I have not thought that we did. And when a school district said, we really want this because we think you do, then we've gone ahead and done it. So we've done both of those things, but I think the clarification point is great because are we truly school contractors or are we health-related institutions that have these MOUs to be able to provide, facilitate a clinical service with the patient and family, and have this space? I think it's just a theoretical question we need to be very, very clear in answering because it might lead us in future directions.
Okay. Steve Pliska?
Yes, I was wondering, do we have a draft of the contract we would have between our HRI and NCPA? Is there like a draft of that we could start looking at or maybe even give to our legal contracting people? I don't anticipate any barrier to us becoming a contractor as an HRI, but it'd be good to be that I would see would be the biggest rate limiting step as far as getting signed up with them and getting the whole process going. Overall, I think this is great in terms of being able to do it one time and then not having to do it with 20 different school districts in different ways and different forms throughout the year. Really would get us off and running when we sign a district up. But it's that actual detail of the contracting that I think we'd want to start looking at as soon as possible.
Thanks, Dr. Pliska. I don't have that available right now, but I can reach out to DPS and ask if that's something they can provide to us.
That'd be great.
Okay. Any other comments or questions? I don't see any. Again, this is why we want to present this on one meeting and vote on the next. And so the team will go and confirm or get clarification on the issue of being a contractor. In the meantime, we'll send the policy out and this information out. We'll ask you to review it, send any comments back to us so that we can, at our next meeting, have a vote and make sure we move forward appropriately. Sarah, Rachel, anything else you need to comment on it? Nope. Very good. You want to go to the next policy?
Okay, so our first TChat 2.0 policy is related to school outreach and enrollment. So this policy does cover quite a few things. I'm not going to go over the policy in full. You all have a copy of that. Your staff have already received a copy of that. But overall, the policy outlines requirements and guidelines for reaching out to and enrolling schools in trait. A number of things covered here: allocation of responsibility for districts and campuses, outreach and enrollment in TChat services, memoranda of understanding, documenting school statuses, onboarding, equipment, outreach for non-public schools, and exceptions to on-campus service delivery. So again, I'm not going to go over the policy in full, but did want to note key changes from current practices with you all. So we do have new expectations for moving unresponsive schools into a declined status. So we are asking HRIs to notify an unresponsive school in writing that they have been unresponsive and after if we don't hear from them after 30 days, we do expect that our HRIs are moving them into a declined status. That does not mean that if they're interested later, that we won't provide services and enroll them as an active school. But as Dr. Lakey mentioned earlier, we really want to be able to provide our state lawmakers with and accurate accounting of where all of our schools and districts lie. We're also asking for HRIs to indicate reasons for any schools that are inactive. This will help us with potential process improvements and changes to our service delivery model. Additionally, campuses that do not want services on site during the school day, we are asking to submit a justification form, again, to help us identify potential process improvements and understand barriers that schools may be facing. We added in expectations for background checks, as I just mentioned, and will make revisions there as needed following your approval. We're asking district leads to enroll campus liaisons and maintain access for their school liaisons. Some of our HRIs are doing this right now, and we're asking for their responsibility to be put on those district leads. We feel like they have the most up-to-date information and should carry that responsibility for the staff in their district. And then finally, expectations for non-public charter school outreach and enrollment have been clarified. So we have been explicit that outreach should really be to public and charter schools only. Any non-school entities we should not be reaching out to, and we should not be enrolling. Then we have private schools and homeschools. So I know that we touched on this a little bit in one of our previous EC meetings about TChat 2.0. Some of our HRIs are currently providing services to private schools and to homeschool students. We want to be able to give HRIs that option if you all feel like it's something that that your teams can manage given your staffing and other capacity. This isn't a requirement, and again, we don't expect any outreach to private schools or homeschools. But again, if you all wish, you may, if a private school reaches out to you or a homeschool reaches out to you, you may choose to enroll those students and accept referrals from those private and home schools. Again, here's our timeline. So we have received feedback from Kosh and from TChat leaders. Today, we're introducing it to you so that hopefully next month you all approve the policy. We'll then begin implementing all of our TChat 2.0 policies in August with implementation support from Kosh. Before I get into questions, I also want to give you a timeline of the two other TChat 2.0 policies that we have planned. So we have a referrals and enrollment policy that is with TChat leadership for feedback right now. That'll be due at the end of this month. We anticipate introducing that to you all in June and requesting a vote in July. And then our services and discharge policy, we have done some initial drafting that will be Kosh will be providing feedback on that starting this week. And we anticipate that TChat leaders will receive that for feedback by June 3rd. So we hope to have that to you by the July meeting for an August vote. Okay, what questions, Dr. Wakefield?
Yes, I have a question about the homeschool versus private school. We have had kiddos who are in a homeschool environment enroll in our services. We've also had requests from kiddos who are at a private school or their families for our services. And thus far we've said, oh, we're not serving private schools, or your private school is not enrolled, and so have not provided that. When I'm hearing, now that I'm thinking about, because we weren't doing homeschools before when I said that as well, and now that we are, there seems to be potentially an equity issue, I guess I'm thinking of as, can we not serve, and this may be a question for the TChat leadership meeting, but could we not serve a kiddo in a family in private school who's requesting it unless the school is enrolled?
Yeah, so we are asking for private schools that the school be enrolled before we accept any referrals. Dr. Ibrahim?
Well, given the spirit of what we're trying to do, which is to make sure that the students have access to these services and having, looking at the number of schools that have not responded to outreach, maybe that's the question for Dr. Lakey. I mean, beyond the team soliciting services, so to speak, from these schools, is there something that can be done at a leadership level to really entice people to respond? Because I think it's kind of left to, I want to make sure that there are no bureaucratic, issues and just someone not being responsive, leading to people, to our students not getting care, actually.
Yeah. No, I think our HRIs have done a good job reaching out to the schools, and we've tried a variety of ways. There is a representative from the educational service centers that's now part of this executive committee. There's a representative from TEA. I think the challenge is your institution and other institutions have reached out to some schools multiple times and haven't gotten a response. And again, I think for clarity so that we can build our budget, we need to be able to say, if sometime in the future you want to come in, we will work you in, but we need to clarify your current status so that we can go to the legislature and get the funding that's appropriate for the delivery of the services. At the same time, the legislature may consider, different approaches. Sue brought up earlier that with the ARPA dollars going away, that there are probably a couple and maybe some of the larger school districts that will want to come in this summer, and we want them to come in. But we need to have some predictability so that we don't have a mismatch of what we think the resources are going to need to be, and then find out that we need to give significant resources back to the legislature after the session.
David, my question wasn't about the policy. I'm actually asking, I realize what you mentioned. I'm just asking at a state, county, whatever that level. I don't completely understand the structure of the school districts.
Mm-hmm.
But should we not be involving state level, county level leadership in those discussions so that those schools sort of make sure that the schools that are being responsive, despite multiple efforts, it's not just some bureaucrat sitting in an office that is not responsive, and ultimately the students. So I don't know if there's anything that can be done to move people who are not responsive to a more responsive state, rather than just having, the local consortium node do that effort alone.
Yeah. And I guess we're open to ideas. And again, that's why we brought in leadership from the educational service centers and TEA to be part of this. There isn't a statute that says that they have to participate. And with that, they are free if they find a different type of mental health services. If they have the dollars to hire somebody, we support that. But we also want to make sure that they know that if they want to use our services, we're available to them, but have clarity related to that moving forward. Yeah, but we're open to ideas.
Dr. Ibrahim, in the policy, we are also asking our HRIs to reach out to their ESC representative before a district has been marked as unresponsive. And we meet regularly with TEA and talk through, the current status of statewide expansion and identify strategies at a statewide level that we can take to help, get more districts into that active status.
Steve Pliska?
Yeah, the one question, could we go to that one slide where it said about the justification form for not having services on campus? One thing I think the policy, I didn't see that in the written policy. I might have missed it. But one thing I think that should clarify is like, what do we do when we get that form? Is it the HRI's decision whether to accept that and on what criteria? this is in fact becoming an issue. A lot of districts saying, well, we'll do it, but only if you agree to not interrupt our school day in any way. And should we just say no? Or if they submit a justification, we agree their justification is appropriate. And should that be a statewide policy instead of a per HRI or per school district, if you see what I mean? There could be a lot of room for interpretation and in terms of whatever they write on that form. You know, one district could say, well, it's inconvenient for our counselors to do it. We don't have rooms. You know, how do we then work through all of that? I think that policy might need to be fleshed out a little bit more, and that could be done at the TChat leadership meeting. Are you finding, maybe you're finding the spot I'm looking for?
Yeah, so
Oh, here we go. There it is. Okay, great.
So we do know, Dr. Pliska, that current practices vary across HRIs when this issue comes up. The policy, as it's currently written, does not state any statewide expectations for how we handle this. I think this it is probably our start for determining if we need to develop some clear statewide guidance about what we should do when a school maybe wants to make TChat available to its students, but not on campus. So we're not asking HRIs to do anything with the information right now.
Right.
But after we have a chance to take a look at that information, we may we may find ourselves in a position where we feel confident, in making additional decisions based on the data that we have.
I do see now we would not be making a decision on the form. That would be kicked up to COSH for the final decision, which would centralize it at that level. So that I agree, that's a good thing.
We work with you, right? I don't want to make those decisions independently of what the HRI feels like they can do and can't do. And so that would be a joint decision.
No, agreed. But at least then it would be, I would feel better that I'm not doing something that's out of line with what everybody else is doing.
Yep. Very good. Dr. Wakefield?
Yeah, I was just gonna say if this occurs, because I'm just thinking of like staffing, and I appreciate the last line in this that says, and the verbal clarification that COSH and UTS might be approving, but you would do that in concert with the HRI. I would appreciate that clarification added to the paragraph, because how it reads, there's this concern that, okay, does that mean we just have to figure it out? I do appreciate the last line. But if we could provide that you do that approval in concert with what the HRI is able to do, I would appreciate that.
Okay. No, I think that's a good edit. Thanks. Any other comments? All right. Well, again, I'd ask people to review and send any additional edits to us, and we'll get those back out. And the goal would be to approve those. And so we have the documented policies and for those two areas moving forward. Any other comments on that? All right. Thank you, Rachel. And let's move next to Dr. Wakefield. I think you're up to give us an update on PeriPan.
All right. Thank you, Lachelle. All right, we're going to talk about PeriPan. Next slide. So we wanted to look at some of the volume as we typically review in this meeting. We have had a little bit of a drop off in volume. We were watching us go up and up and up since everybody came on board together last fall and we started enrollment. And then in the spring, we've seen somewhat of a decline. So we're not really sure what to make of that. There have been some holidays in there, spring break, that kind of thing. But we typically see that affect child flows, child referrals, and don't really have a good cadence for understanding if that's a typical thing to be expected in perinatal psychiatry or not. That's something that we're watching. So we are taking a look at that. We are happy to see that we continue to have people increase in how many people are engaging and calling at least once. So that's exciting. And then not much change. We'll look at clinic staff roles on our next one. Any questions? We're still having a lot of people refer. So about 14% refer to a local adult psychiatrist. So when we're meeting one-on-one with teams every month, we're encouraging them to make sure if they think a psychiatrist is something that a woman needs, that we could start with a PeriPan direct patient consult, that is a service that's available statewide to all of our PeriPan hubs. Even if you don't have somebody to provide that direct patient consult, there's another hub that it can be transferred to do that direct patient consult. And again, even, we're not sure about the access, the ability to get somebody in. But even if we are, many times women won't go to those appointments because of the stigma associated with it. And so always helpful if we can help that OB, PCP, that frontline clinician with those next steps. It reduces the burden of symptoms, of appointments for that woman, and often reduces the stigma of treatment to get it in their medical home. So wanted to remind everybody about that and encourage that. And it's something we continue to talk about in our one-on-ones. Any questions about this information on this slide? All right, next slide. So we wanted to show, sometimes there are some calls about what our others are. So we continue to have obstetricians call the most commonly, and then we have some trainees call second most commonly, and we don't have the ability to say who those trainees are yet, but we are working towards that model. Our second, when we look at type of clinician calling, second most common is a pediatrician, and then our psychiatrists and family medicine physicians, physician colleagues. And so very important information that we have pediatricians calling our line a lot to ask about mom. As a reminder, the pediatricians have a higher burden or a higher recommendation for screening mom because of those postpartum well visits, or those well visits that happen for the child that happen in the postpartum time period. So we are seeing them call, and we like them calling, and we want them to call. And we want to remind all pediatricians that they can call if they've screened mom, they're worried about mom during a well baby visit, and that we can help with next steps in care. We're also here to support our psychiatry, our general psychiatry colleagues who may have a question about medication management. And so as a reminder to all of your clinics out there or other general psychiatry colleagues, if someone gets pregnant and one of their patients gets pregnant, as might happen, and they have a question, that we can be calling PeriPan and asking those questions and trying not to have to shift care or stop care, but provide that woman the best care possible and have her have the least burden of appointments as possible. We looked at the other specialty because that has come up as a question before, and wanted to show you that we have nurse practitioners and certified nurse midwives and physician assistants calling in those orders. So nurse practitioners the most frequently, certified nurse midwives second most frequently, and then physician assistants. Next, any questions about this? Sorry. No, okay. This is our grand rounds or our webinar schedule for 2024, and we are currently in May, so about to have psychotropic medication and breastfeeding and pregnancy happening tomorrow. And so this happens on our third Tuesday of every month from 12 to 1. It is open to anyone who wants to attend, any type of clinician. It is webinar based, and you can listen. You don't have to turn your camera on. I think these are fantastic resources. We have a wealth of expertise across our state, and many different clinician experts delivering these from across all of our HRIs. So this has been really great to see. We are planning on developing a 2-year curriculum so that we have some rotation, but some redundancy as well, so that as new people come in and are finishing treatment or training and coming into training, that they're able to come to these grand rounds or webinars. We also have these available on our website. And so if there are residency programs that are interested in watching these as part of their didactic curriculum, that this is available to everyone to watch. We are developing pearls for our residency programs, our general psychiatry residency programs, that will go, and obstetrician residency, pediatric residency, so family medicine, but pearls that will go along on the website with the webinar of like, these are our highest yield facts out of here, and this is what you need to know, so that they can print those out and review those as well. We were developing a different type of training model for our general psychiatry residents for perinatal psychiatry. And I presented some of that just in conversation at our recent ADPERT meeting, was able to get a lot of feedback from various general psychiatry residents in Texas and training directors in Texas. And so we revamped that a little bit to be more, hey, they can access it they can come, if they are able, to the grand rounds when it's being presented. They can access it on our website, and they can also access that kind of compendium of resources that will go with the webinar, to be able to have that to reflect on and review and look back on. Any questions on that? Okay, next slide. So we also have our spring echo series. We do a spring and fall echo series with PeriPan, similar to CPAN, but we do our statewide all together. We're in the midst of this echo series as well, with next one being on 5/28 for focused on hyperemesis gravidarum. And then we have postpartum catatonia in June. We are looking forward, next slide, to a fall echo series that we're partnering with the Texas Pediatric Society. They are working on an echo series from June to October focused on postpartum depression. So Jen Ertigi and myself have been a part of the TPS postpartum depression work group for this echo series. It will be offered in place of the PeriPan fall echo series, so that we won't be asking people to do even more things and go to more things. But we've been really excited about that and hope that we are plan on co-branding that and co-promoting that, so that we really get lots more pediatricians engaged in looking at postpartum depression, how to assess, how to respond, how to talk to moms and families and partners about expectations around postpartum depression. So we're really excited about that partnership. We are also in the middle of gearing up our pathways to perinatal mental health equity. This is a project, the PCORI grant, or the PCORI project that we're working with with Lifeline for Moms, that we approved a few executive committees ago, or maybe a couple of them ago. And so we're also working with DSHS in identifying the regions of Texas and the related to what's called the Maternal Vulnerability Index. And so when you look at this map, the darker the square, or the darker the whatever shape that is for the county, the higher the maternal vulnerability index, or MVI, is. And so we really looked at some clinics in those regions to identify. We're contacting the HRIs in those regions to say, hey, do you have relationships with these clinics? We have a rank order list of maternal vulnerability index, and those that would meet the birth or delivery number for the PCORI. And then we are working with HHSC or DSHS to say, how can we all work together with Texas, the PQC in Texas, the Perinatal Quality Collaborative, in order to really look at how we can work together with our state agencies to expand what we're doing in Pathways statewide. It's really exciting. As a reminder to everyone, the goal in Pathways is to help outpatient clinics implement the new AIM bundles, the Alliance for Improving Maternal, I'm always forgetting what that stands for, Innovative Maternal Outcomes or something like that. So implementing some of these screening guidelines that we know are helpful in response to the screen for postpartum depression and anxiety, other maternal conditions. And we'll be looking at screening for substance use as well in the statewide rollout. So we're working together with all of them, really excited. And I think that's all about those. And then for the last, for Peri-Pan, we just wanted to show enrollment. We are up to 875 obstetricians across the state, 164 OB clinics, 41 women's or maternal health clinics, and 13 midwifery practices. We are continuing to really focus on enrollment at this time across our state with all of our HRIs. We saw a steady uptick in enrollment, and now we've seen some leveling off of that. So we have some work to do to continue to enroll obstetrician practices across our state. I think that's the last slide. Yep. What questions does everybody have?
All right. I don't see any questions. Any questions from anybody? If not, thanks again, Sarah, for all the work in rolling out Peri-Pan. Again, a lot of work across the state of Texas. A lot of our programs, there's been a little dip in numbers at certain times of the year, and then they go right back up. And so I look forward to seeing how those numbers play out during this period. So great. All right, let's transition next to the next item on the agenda. We're going to have an update on the outreach and engagement efforts conducted by the Center for Health Communications at the University of Texas at Austin. Melanie Susswine, let me turn it over to you.
Hi, everybody. Thank you for doing the slides, who's ever operating that. First of all, before I launch into mine, happy anniversary. Today is the official anniversary of CPN, 4 years. So we'll be talking about that a little bit and some of the things that I show you, but congrats. Okay, so next slide, if you will, Lachelle. This is what I'm going to go over today. When I talk about our outreach and communication, I'm going to spend some time talking about partnership, what we've done with branding, social media, what we're doing today around the anniversary, and then give some update around our new work with TChat this year. Next slide. Okay, so the power of partnership. So this year, part of our communication outreach is really to solidify and use our partners work together to get the messages out about CPAN and Peri-Pan. So 3 groups that we are working with quite closely are the Texas Pediatric Society, the Academy for Family Physicians, and ACOG, our district in Texas. So we do things like at the Texas Pediatric Society, we have a dedicated newsletter that we write and support, and they put it out there. As Dr. Wakefield was talking about, jointly branding and this initiative around the Echo Together, that was in this month's newsletter, and we'll have continued information upcoming, and also working on whether we could do some posts that we share together around those kinds of things. The Texas Academy of Family Physicians, we've gone to conferences. Dr. Williams went to one of their lecture series and spoke. We've showed our Peri-Pan films there, the short clips to raise awareness. We're so thankful and grateful for their collaboration, putting our information in their newsletters and promoting our posts. So really working on that. And then with ACOG, Dr. Olson has just been so wonderful to work with. You see here on the left with the little arrow, a short video when we had the CPAN and Peri-Pan Summit. She was there and we did a video of her talking for Mental Health Awareness Month. That was in our social media. And to the right, you can see the PeriPan Mental Health Toolkit, which has been launched. And Dr. Olson and Dr. Wakefield did a 10-minute, it was so perfect. They were amazing, a 10-minute webinar about how to use this toolkit together. And ACOG has done a tremendous job in promoting it, sending out in their newsletter. We have on our website now, if you go to the PeriPan webpage in the resources, you can link to where the toolkit is, and there's several different downloadable pages for physicians and clinicians, and then also for them to share with their patients. And I think the toolkit is just such a wonderful resource, and ACOG has just been an amazing partner around it. Next slide, please. Lainey presented a couple of sessions ago, I believe, about the rebranding efforts. So we have worked on those for a long time, updated, over 200 files to create the CPN and PeriPan brand together. When we think about the materials, we think about the way they go, our HRIs interface with clinicians in their offices and who's going to be receiving these, and we want them to speak to each audience. So we have statewide CPN level materials, but most of the time, it's CPN and PeriPan combined, because we want people to know about the two programs. So most of the materials have been developed that way. We also have them for only PeriPan in case HRIs are going to speak directly to OBs, clinicians who do not in any way see children. We also have created materials so they can be statewide and that they can also be developed for the HRI to have that personal regional touch. Next slide. Our social media, over the last year, we've worked very hard with the partnerships, including having some short videos, which we've done a lot over the last few months. There are a lot in this month's social media, and we see that the response to the videos is very good. So that's why we're doing that. And we're being out and about in the community and with our partners. So there's opportunities to film short snippets and how the end user is really interfacing with the program, which is what you see on the right. But we have had a 143% increase. We have 445 followers on LinkedIn, and then we have a 29% increase in Facebook with 669 followers. And we're reaching, tens of thousands of people with our posts. I pulled out here to show you some dialogue that we start to see, which is really nice. We have a couple of nurses talking about the ability to text and sharing that information with each other as an important program highlight. So that's always great, and we like to see it. Next slide. Okay, so like I said, today is our 4th anniversary. These are QR codes that you can all scan while I'm talking about this that will lead you to the Facebook and LinkedIn pages for CPN and PeriPan, so that you can share and comment about CPN and PeriPan and about the anniversary. What we are doing for the anniversary is we have created newsletter content that our partners have distributed to their partners. We wrote it for each partner individually. We also have posts that we shared with them that talk about their partnership with us. We also created newsletter content. You can see that to the right, Dell's newsletter, where we're all messaging the same thing about CPN for the 4th anniversary. And we have 2 posts about it, at least 2 posts in this month's social media. Next slide. And then this year we've been really getting to know TChat and doing kind of our formative research process and learning about TChat before we start updating any kind of materials. So what we've done is in conjunction with Lainey, gathered the materials for TChat that are being used around the state. We worked with the director of the Center for Health Communication and a couple of PhD students to review many of the materials and put them in look at them through the lens of health communication theory to develop recommendations for the materials moving forward and seeing where the opportunities were for some of the materials. With the TChat materials, we're really looking at how we can provide updates, consistent language on the parts of the programs that are universal, and then provide content for people, for the HRIs, that can be updated based on the particulars of that HRI. So we're working on a content library out of this. One of the things, I've spoken about this before, I believe, when we did the PeriPan and CPAN research at the beginning of our work with y'all, is we love to see when the data is redundant and really comes together. So based on the HRI interviews that we've done, we had listening sessions with each of the HRIs to learn from them about their processes, what their needs are, the opportunities that they see, what they think is going well. And then we had interviews with counselors around the state, similar lines of inquiry: what's going well, what could be improved, what are the opportunities, how do you describe the program to parents? Then what we're doing right now is parent interviews. We're interviewing parents from around the state in various stages. They've all finished or are not currently using TChat services, but we're looking at folks who have been enrolled and completed, who were enrolled and then declined services, who were referred and never followed up, or people that they were never able to reach. And we're conducting interviews with them to learn about the communication process. So we're in the recruiting and interviewing stage. I've done 6 interviews out of 24 so far. What's next for us is a library based on all of this information and some new materials that we will create in a way that are flexible and consistent for the HRIs. And again, just that the data has been corroborated and redundant in many of these areas is wonderful. We know that we're on the right path. Next slide. I think it's just questions. Any questions or comments for us? No? Okay. Well, thank you. Please, I hope you will take a minute to like and share the posts today for the anniversary. Your credibility with your audiences, sharing that helps CPAN and PeriPan a lot. And then again, just congratulations on 4 years of this.
Thanks, Melanie. Again, thanks for the ongoing hard work to get our messages out there. So it's really appreciated. All right. Why don't we now go to the update from the internal evaluation team about data and metrics related to the consortium projects. David, I think you're going to lead this, and I don't know if Molly's here today. She's on. Okay, I didn't see her.
Yeah,
let me turn it over to you two.
Molly will take the lead, and then we'll chime in here.
Sure, I'll start us off. Good morning, everyone. We're happy to share a few updates from some of the work that we're doing and just highlighting a few of those things. Varun, our data manager, and I are working to finalize a TChat presentation dashboard, which we really hope will assist in having regular monthly updated data for presentations. Knowing that there's so many of that wonderful communication happening, we want to make sure you all have easy access to data. We're also working on the upcoming TChat Summit and excited to be able to share there about the progress that's been achieved. And then I really want to take a few seconds, really. I'm very pleased to introduce our newest team member, Cynthia Smith, who is serving as our Salesforce administrator. And Cynthia is really kind of ideal for this role. She graduated from the Steve Hicks School of Social Work at UT Austin, and I'm not biased at all, having come from there, but working there. She also led the implementation of Salesforce and Marketing Cloud at Austin ISD. So she has wonderful school experience as well. And then led implementation of Salesforce, went on to be a Salesforce marketing consultant and a CRM automation strategist. So she has really jumped into the work quickly. I'm going to pass it over to her and let her give a brief update of where we are.
Thank you, Molly, for the introduction. Nice to meet you guys and so happy to be a part of the team. Just in terms of where we are with the Salesforce implementation, we are moving forward with our procurement of Salesforce. The team worked together to identify the correct edition of Salesforce, and so we finally landed on what is going to be most beneficial. And then also through Marketing Cloud, did some exploration of the different products that are available from Salesforce and have decided on the edition that we are going to purchase. So in process now, we do have a proposal from Salesforce on the Sales Cloud. We're waiting on the proposal for Marketing Cloud, and that will move through the contracting process. We have also put out a request for bid for a vendor to help us with the implementation and have gone through that process and are finalizing the selection of that particular vendor. So moving forward, hope to have more updates next month, but definitely on the right path and happy to be here.
All right,
Thanks.
David.
Oh, sorry, Molly.
Just passing it over to you.
Yep, thanks. Morning, everyone. David Lynch. Good to be with you all. Quick update today on a PeriPan related item. As with the other programs, CPUE, TChat, and CPAN, we want to actively solicit feedback from the end users and program staff. And so we just installed a new PeriPan experience survey at the time of enrollment and after the first consultation, asking questions like, how was your experience? How can we make things better? How can we be more useful for you? And so we just launched that. It's a blend of quantitative and qualitative questions. Just about 2 weeks ago, we launched it. And so nothing to share more than that update right now, but looking forward in the future to share some summary results. And if anybody has any questions about that or any other item that we presented here, please reach out to us. We'll be happy to talk with you. I think that's it for our update.
All right, very good. Welcome, Cynthia, to the team. Look forward to all the work they're going to be doing for us. All right, any questions for the team? Hearing none. Linda Haster, we're going to go to you for the update for the fiscal agent for the ARPA funds.
Sorry about that. I was trying to get my video and things to work. Thank you. Well, good afternoon. So go ahead. We can go to the next slide. Thank you. All right. So I wanted to give a quick update to let you know that we have made a lot of progress on the executed amendments since we last reported. So we have 15 out of the 21 that are fully executed. So that will help start expediting some invoicing and stuff to start coming back on reimbursements for the HRIs that were doing the work during the negotiation phase. There are 2 HRIs that are out for signature, and there's 4 others that are waiting for budget information. So those agencies, if you want to visit with us outside of the meeting and stuff to let us help you trying to push those budgets along the way so that we can get the executed agreements to both sides executed, that would be great. Next slide. So here is an update to kind of show you where we're at so far. So total expenditures to date are at 34 million, but we do anticipate that with the executed agreements, we're going to start to see HRI start catch up on billing and start sending us some more reimbursement requests now that we have the new extension on the contracts. And so for TChat, we're at the 19, CPAN is at the 9, almost 10 million, and the CPWE is at the 5.8. So this is a quick overview based on the program itself. And then we have as a companion piece on the next slide, it shows it by each of the initiatives, and it compares it to budget. So we can have an idea of our burn rate and where we stand today and how much work we have to do to kind of align the work with the expenditure part of it and get those reimbursements and the costs spent so we can kind of exhaust the federal portion of our budget. Next slide. I think that is it. Oh, so this is the one that's by initiative. Apologize. The one before was the budget comparison that I had noted, but this one breaks it down into a little bit more detail by each of the initiatives that we've had. And it does also the comparison based on the budget that we've allocated for that program versus the expenditures to date that we have. Next slide. And that's our contact information. I just want to play a key note that if you don't recall, we had been meeting with you on the monthly check-ins, but the billing for the reimbursement for the sub-award reimbursements go to Elise now. And so just make note that you've always been copying Laura and Joy when you submit those, so they still get to us, even if you're still using the old contact for Rachel, who moved on to another position. We just want you to update your records to show that Elise is the contact person for any reimbursement requests. And are there any questions?
Any questions for Linda? All right, I don't see any hands. Thank you again, Linda.
Sure, no
Thanks.
problem.
All right. Now we're going to transition to the research initiative. Nagla, I'm going to turn it over to you.
So just an update on the new and emerging child mental health researchers. We had 47 completed applications that were submitted. And that makes up 5 of the postdoctoral fellow and trainee, 11 research career development, and 31 research grant applications. So where we are right now is we're in the review process. So the review started about May 10th, and we're expecting to complete the review process by July the 2nd. So that includes both the individual reviews, and we're going to do a couple of group reviews of the applications. And the intent is that on July 15th meeting, that we will come here and present the finalist for an approval process. So these are our next steps. So we're currently in the review process.
Yeah. So we had a very robust application process. Again, thank you to everyone that was part of that. A lot of good applications, young individuals that were seeking funds. Again, for those that haven't been part of this conversation, each of the institutions could endorse 6 applications. The applicants needed to talk to the chairs of psychiatry in order to meet the criteria and to be eligible. And that seems to be working well. The peers are all from outside the state of Texas. And a lot of enthusiasm there to be part of this review process. And then we had a couple of actually there are 2 individuals that are inside the state of Texas, but they're not at any of the HRIs. We have 1 individual representing the local mental health authorities and 1 representing HHSC. Again, their role is to make sure that the questions that are being asked are the right ones in order to improve the mental health system here in the state of Texas. So I do have the second item there under research. This has been very robust. There's a lot of good applications out there. There isn't enough money to fund all of them. We want to fund as many as we can possibly fund. But when I look at the research dollars in general, it looks to me like there's some dollars that are not obligated for the fiscal year 24. And the 2 large studies that we have, that the trauma study and the depression study, it looks like to me that there's going to be some unused dollars. I'm not sure exactly what that number is right now. We need to have some more back and forth with the hubs and the nodes related to those projects, but I don't want those dollars to go to waste. And so I have need, and then there may be unused dollars. And so we're going to ask for a vote, a formal vote from the executive committee so that you allow us to use those unused dollars to put into this project. And again, I've worded it so that it's flexible. I put up to $2.5 million of unspent funding from those two projects. For the current budget for this new and emerging child mental health researcher program. If it comes out that when in the negotiations with the hubs and the nodes that number is only 1 million, that is fine, and we'll use those dollars. But I wanted it to be as flexible as possible so that as we're looking at the numbers, if it turns out that there's a large amount of money, that again that we can immediately push those dollars into these young investigators across our universities, the 12 universities. So I'm happy to take any questions, but again, that the goal is to return these dollars to you in a different form, in a form that will fund the young investigators if the other projects aren't able to use all the funds that we allocated to them initially. Any questions? Okay. All right. If I don't have any questions, is there anybody that would like to make that motion?
I'll make the motion.
I have a motion by Dr. Polowitz.
I'll second it.
Second from Dr. Suarez. Any further discussion? Hearing none, all in favor signify by saying aye.
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 Anybody opposed? Did anybody abstain? Okay. So I'm going to take that as a unanimous approval of that motion. And again, we will continue to work with the two large research projects, the nodes and the hubs. But we want to, again, we want to do it today, that have that motion so that as this review process is taking place, that we can push as much money as possible so that we award the numbers, we can award as many of those grants at the same time as all the other grants are being named. With that, why don't we transition? Dr. Williams, I see you. Laurel, why don't we go to the update related to from Kosh?
Okay, sounds like a good idea. So it's the 4th, and so everybody knows me. I'm a Star Wars nerd, so as I know it's not the 4th anymore, may the 4th be with you. Next slide. Yes, thank you for the chuckle, one person. So for our CPAN consultation volume, we are seeing another sort of lovely increase as we sort of redouble our efforts for outreach. And so in April, we closed out at 1367 with a great response time to the physicians that are asking to speak to our psychiatrists within 30 minutes. So we're continuing to see that growth in the clinics, the number of providers, and the consult activity that we have for CPAN. Next slide. And this just goes to show you, because that previous view is just looking at the past 6 months. You can see the year-to-year growth between 22, 23, and this year starting in January of 2024. So again, we anticipate and continue to expect continued growth as we particularly get the message out that direct consultation is up and running across the state for our CPN teams as well as for PeriPAN teams. Next slide. We are paying a little bit more attention, as we've talked about in the last couple of executive committee meetings, as far as the sort of work within the CPAN consultations with our child psychiatrists. So you can see here the total number of consultations between March and April. And then when you look again at the number of times that when we have a consult come in from a nurse practitioner and a pediatrician, a family doc, how often are those consultations including our child adolescent psychiatrist? So you can see March, April, 38, 39% of the time our psychiatrist is getting involved. Now, this is a very important piece of information and data, because the way that a primary care physician could potentially have a direct consultation for a family or a woman is that they first need to speak to one of our psychiatrists. So we really want to make sure that as applicable, that we really are having our psychiatrists be involved in the consults. It will never be 100%. That's not the goal, but we want to make sure that our physicians are talking enough of the time to really help a pediatrician or a family doc or OB walk through what their question is, because sometimes you don't know what you don't know. And so really having our psychiatrists participate in those calls at the very outset can help us find those consultations where a direct consult may be of benefit to the pediatrician, PCP, and the family and woman. So as you can see here in April, the total amount of time that our child psychiatrist was involved in the call, that's the total referral, is 173 times out of the total number. And then the number of times that we were involved if there was a request for a referral. So this one always is a little bit confusing. So percent CPAN cap involved in referral. Our pediatricians, our family docs, our OBs can call and say, could you help me find a psychiatrist for this patient? So when the request is for our team to find a referral for an outside psychiatrist, we really, in those instances, very much want to try to ensure that our child psychiatrist or our reproductive psychiatrist potentially is able to talk with that primary care doctor, because as we all know, there's a long wait list to be seen in psychiatry. So we're hoping that if we can have a direct conversation whenever the primary care is just wanting to have a referral, that some of those can also be converted to a one-time direct consultation. So we really are working with our teams to have that number rise where whenever they want a primary care wants a referral, that our psychiatrist gets involved in the phone call. And then just the number of direct consults that we've done across the state also went up to our highest month ever at 62 in April. So we're really glad to see the number of direct consultations continue to go up and up and up. Next slide. So the QI projects that we are working on in particular is related to our physicians being able to reach out to providers who've already been enrolled. So we're not asking for our psychiatrists to connect with physicians who've not yet enrolled in the service. We're asking for our team members who are on CPAN that day to be reaching out to primary care physicians who've already been enrolled, leaving a message. We're never trying to pull a doctor out of their busy day, but leaving a message so that they can call back and then have a better conversation. What we've discovered that probably is not surprising to many of you is that everybody's just very busy. Physicians are very busy, their nurses are very busy, their front office staff is very busy. And so sometimes when you're very, very busy, you don't always sort of internalize the message that what CPAN PeriPAN is and what it can do for the primary care physician. So we have gotten feedback from our consultant with Lifeline for Moms and MCPAP that we really should be using our own psychiatrists to make that message become clear by having a physician-to-physician conversation. So each of the teams has the data that tells them which physicians are enrolled in CPAN but have not yet used the service. And those are the people that our psychiatrists are reaching out to in this QI project. And in April alone, our psychiatrists made over 568 phone calls to leave messages that resulted in 7 calls back that turned into a CPAN consultation, 20 that resulted in an education about the CPAN service, and 3 that actually resulted in us being able to do an ethics presentation to that physicians group to really help them understand the need and purpose for a CPAN PeriPAN-like program. Just like all of our other outreach efforts, we don't necessarily imagine that we're going to get some large amount of times when, Melanie was talking about how many Facebook friends we have and the messages. This is something that we do think will be multiplicative over time. And this is only the first effort of making a phone call. And we intend to continue to reach out to providers who've not yet used the service multiple times, and in order to help them understand the service. And again, if they get on the phone with one of our psychiatrists, having our psychiatrists support them even in that moment with a CPAN or PeriPAN consultation. Next slide. We are now working on our third sort of resource work group. We're working to standardize the type of materials that we hand out across the state. So no matter where a provider calls, they will get the same high level of resource assistance. We did already psychosis and eating disorders, and now we're working on anxiety, which is of course a pretty large topic. And the teams have all put all of their resources into the pile. They've been sorted by a type of resource, by the audience that the resource is meant for. And so now each of our teams are working to the local statewide experts in anxiety disorders are now being asked to review those resource lists, make sure that we have the most up-to-date best ones, retiring resources that might be felt to be out of date, and adding any new ones that we maybe have forgotten. And the next topic that the resource work group is going to be working on is depression. We are talking with Dr. Wakefield and Jen Erderidge around how to do this process as well for perinatal resources. And so we anticipate over time that we will have this, again, it's a statewide effort. All teams will have access to this information, and the expectation is for all teams to be trained in using our resource list to provide vetted materials. This is not about the finding of a referral. That's a separate process that is statewide. This is about a resource. Hey, I want to send somebody, an article, or I want to send a family a book recommendation for a child that has anxiety. So these are the kinds of resources that we're talking about. The referral resource process is WellMedi, and we are also working to improve that standardization. Next slide. We are also going to be working on CME standardization. When CPAN first started, obviously we were very excited. Again, this is our anniversary, as Melanie pointed out. All teams worked to sort of develop outreach efforts that included providing continuing medical education for primary care physicians. And so in any given month, we have 2 to 4, sometimes more CMEs that are going on across all the different HRIs every month for CPAN. Now, when PeriPAN launched, they launched in a slightly different way, where they sort of had one sort of CME topic that you saw Dr. Wakefield share a minute ago, and one Project Echo. We're going to be working to actually standardize that process for ourselves. And the first step for that is we already have a wonderful set of decks for CME that a lot of different people in our state hubs have created. So what we're going to do is start with one topic and do a work group with our with 6 to 7 psychiatrists to kind of look at all the slide decks that have already been created on a particular topic, and standardize to have maybe 1 to 2 presentations on a particular topic that then would become our statewide decks for CPAN. And then whenever somebody needs to do a CME on a topic, they could pull down one that's already been state approved, and anybody in our CPAN, PeriPAN teams could utilize them. So we can kind of focus less on content creation and more on just delivery across the state in a standard way. So teams will still have the ability to create, one-off presentations. They will still need to follow the process that's been reviewed and discussed, that they first have to send them to Laney for a review, and then the review for the scientific content of it. But we're hoping that by having these sort of standardizations for CPAN, it will really kind of help streamline our processes, streamline maybe some of the budgetary asks, and really make sure that we are kind of delivering CPAN in sort of the phase that we are now, separate from the phase that we had 4 years ago with startup. Next slide. We are working with Trade as far as development of some really large features. So the biggest large feature that we're working on is that direct patient consultation process. We actually took some notes from our T-chat processes because it is obviously about patient care directly. And so the goal within the Trade platform will be that the team members that need to be involved in helping reach out to families or women, get consent paperwork done, get patients scheduled, will sort of all be really nicely housed within the application, including for the psychiatrist, so that as we work through the steps of having a direct consultation, we'll be able to track that very closely and cleanly, and at the end be able to show that information to the PCP, as well as for our teams across the state. The other one that's in conjunction with that is the PCP web portal. We are working again to have, the hope is sort of sometime in the August timeframe that both of these will be available. So the PCP portal will allow for the primary care physician to put in a consultation request. Even after hours, it would load then, for our team, so that when we get into work the next business day, we'd be able to open it up and be able to work that consultation. So for PCPs that maybe are super busy, which they all are, and they maybe don't get a chance to think about a direct consult or need help with a question until they're in their evening time writing their notes, charting, that they would be able to go into the portal, ask their question, it'd be sent over to our team could respond. And additionally, be able to send the materials directly to them so that they would have it for their own EMRs if they so desired to sort of upload things. One of the things that will be important for the portal is to have the NPI as a unique identifier. So Trade has been working to define those requirements and do a crosswalk with the internal evaluation team as it relates to physician Texas licensure and NPI number and Trade's unique identifier. So things going on in that direction. The other piece that we're working to do is right now, when we do the internal evaluation, wants to have the surveys sent for primary care when they enroll in CPAN, and then as they use the service, we are going to be having those become something that also is automated within the Trade application system, so that the first time caller would just automatically get assigned the engagement survey versus our teams having to remember to send out the reminder request for the pre-CP. So that also is under being defined requirements wise. So a lot of great things down the road to kind of make the program for CPAN PeriPAN run more efficiently on our end as well as on the PCP's end. Next slide. Moving now to T of the chat. Next slide. So as you can see here, this is again a slide that we've been showing you now for several months. This is just looking from year to year and that amazing growth that Dr. Lakey and Rachel sort of alluded to at the top of the presentation with MOUs in the schools. So we continue to see obviously that very clear seasonality that youth mental health care has between summer and then winter breaks. We had a weird sort of decrease in March, but we actually think that has more to do with testing that often happens in schools, and maybe this year was just a little bit more obvious. Again, for those of you who aren't aware, there is typically STAR testing throughout most of March for kids in the state of Texas, but we bounced right back with April with again a pretty significantly large amount of referrals across the state. Next slide. So this is again just this school year, so that each of the lines reflects a different aspect of the referral process. So first, a young person has to have a referral that comes from the school counselor. That is the blue line. You can see the number of students that are referred in this school year. The next line is involved with us, as because we are a healthcare service, kind of back to the earlier conversation we had that Dr. Wakefield and others were talking about. We won't see a young person until we're able to reach a parent or legal guardian. And so at that point, once we are able to reach a parent or legal guardian and the parent or legal guardian agrees to the service, then the student becomes enrolled. So that's why you see a very big difference between referred and enrolled, because we will not schedule an appointment. We will not see a young person without parent or legal guardian approval and presence. And then the next line, the gray line below that, is the number of students that have had at least one encounter with our TChat team. And so these numbers, because there can be some changes from month to month, we really will want to look to see at the close of the school year kind of where things lie, because there could be some movement. Sometimes it takes a long time just to get a hold of the family. And so there can be a lag between when a child's referred and when we're able to enroll them. And as well, sometimes after we reach the family, they're like, well, that's great. I like the appointment, but can we do it 2 weeks from now or something? So we always want to follow what the parent's preference is when it comes to when the patient student might have their encounter with their TChat team. Next slide. So this is the number of treatment sessions that we were able to do and the number of students that were served. So you can see here, just it's a nice way to kind of look at the sort of continued growth of our service and the number of students that have been served for TChat. Next slide. And then you see here, this is percent of sessions by provider type. We've talked repeatedly about this sort of concept that the vast majority of young people that are being served in TChat are receiving services that involve therapy, individual therapy, and then also case management. So we do have our physicians and NPs that do see young people when the families request it, but that is a much lower percentage than our overall work with their LPCs, LSWs, LCSWs, and psychologists. Next slide. And then this is just sort of, again, looking at the number of sessions. The earlier one was the percent. This is now the number of actual sessions. So again, it just sort of follows that. Again, mostly the young people are being seen by our therapist. A smaller amount of time they're being seen by one of our physicians and or nurse practitioners. Next slide. And then this is going back to that percent view as well. If you prefer percents versus the sort of total numbers, it is essentially saying a similar thing. The last slide that we wanted to share before we talk about some of the updates is that we are moving for TChat into a direction of being able to have some assessments that are regularly done with families to kind of help guide care. The assessments can do two things for us. One, they can kind of make sure that we really have a good understanding about what the child's challenges may be as they're having their very first appointment with us. And then subsequently, if the young person is felt to really have a struggle with anxiety or struggle with depression, that we would periodically be doing another scale to make sure that we're making progress with the young person and the family. And so this is before anything has been required or with our teams. We just have this called a heat map. And the one that is required right now is the CIS, the parent. And we have, for the initial one, we have some really nice numbers of families completing the initial. What sometimes they're struggling with is repeating the follow-up. But we are working with Trait currently to have that process be automated so that the families and the counselors, therapists, excuse me, not counselors, the families and the therapists and the physicians for TChat are not having to remember to do it, that it'll be automated. So as we move into the new school year, and we have approved the number of the types of assessments that we're going to do, these will become mandatory and then they will be automated. When we say the word mandatory, I just want to also be clear that we are never going to not see a family or a young person because they were not able to complete a measure. We always will value and prioritize the patient care. So if a family elects not to complete an assessment or feels unable to do it for whatever reason, our TChat teams will still see the families and still see the young people and help them. But we do really feel like these measures will help us make sure that we're making the most progress that we can make with young people, and as well as we start to work to provide some of those additional services for trauma and substance, being able to really make sure that we have some good information about the level of distress, level of functioning as it relates to the different concerns that we'll be helping families with. So this is just kind of a very preliminary, how well the teams are actually doing without even it being mandatory just yet. So we anticipate with having it become automated, that it will help our TChat teams and families even more be able to complete those assessments. That's what this slide's about. Next slide. So there's a lot of things, just like for CPAN, there's a lot of things that are projects in process for TChat. As you just saw earlier, there are policies that are being reviewed. All these policies are worked through with the UT systems oversight and guidance. The TChat leadership team assist as well. Occasionally work groups are created to really think them through before they actually get to the executive committee for everybody to review. Jen had worked with the CHC to get the counselor and parent interviews going. And so that's, as Melanie said, been going very well. Appreciate all the information they've already been able to supply and provide us. We have gone to a few of the HRI sites very specifically to support TChat teams as they're working to address challenges, make their processes more efficient, work on their organizational structure, particularly as we move into this new phase of TChat 2.0, as well as just working with all the HRIs and that sort of implementation process. We're working with UT system as well. And it's kind of to that earlier conversation about educational support centers and HRIs. All of our TChat teams have really strong relationships with educational support centers. We, along with UT system, work very closely with the TEA. And the goal is to really make sure that we are able to reach the right people at an ISD so that they can make have the knowledge about what TChat is, so they can make an educated decision of whether or not they would like to have their ISD participate. We have had a few of those larger school districts that had been initially hanging back across the state who've now come forward and said they would like to partner with TCHAT in those regions. And so each of those HRIs that have these sort of really large, and Houston has a really large one that just signed on. We are actually working to coordinate how that will go because those are pretty big districts. And so we want to be careful and cautious that we can provide all the services in a timely fashion. And then, of course, the UT system is leading the charge for our second TCHAT Summit and cautious assisting in that support process so we can have another amazing summit in June. And I think that might be the last slide. No, it's not. Okay, haha, guess I was not remembering all the slides. But I know this slide, and this slide is about that assessment work group that we were talking about, that I was talking about when I showed the heat map. Probably should have put these two together. My bad. And so we do want to make sure that we have a very sort of streamlined process for assessment. So part of the work group's charge was to really make sure that we are really not burdening children and families unduly as it relates to any assessments that we're going to be asking for families to do. As you can see here, for children that are 10 and under, we'll be using the SCARED, which is the parent required, child optional. This is a measure to look at broad types of anxieties that young people can have. The SNAP is the next one that is going to be asked of for the parent only. Again, this is a measure to look at attentional and hyperactivity symptoms for young people, as well as that CIS that we've already been doing that we had agreed upon last year, the Columbia Impairment Scale. For the young people that are 11 and up, we will have a couple of more scales, and this is also just kind of go to, as people get older, there are sort of more complexities and more things that we may want to consider or think about when it comes to young people in that adolescent phase. We will be doing some of the screeners on the actual visit itself versus in advance because of some sensitive questions that we wouldn't want to have somebody answer without having an appointment that's coupled with it. So the PHQ-9A and the Columbia Suicide Screener will be the day of the visit. The other ones will be sent either to the parent or child prior to the visit. So the GAD-7 is an anxiety screener. The CRAFT 2.0 is a screener for substance misuse. And then it's, again, the SNAP and the CSI are ones that we also are using with the 10 and under CRAFT. So the goal will be for young people and their parents to complete these measures on the prior to or on that first appointment. Again, as I said, nobody will be denied a service if they're not able to do them, but we will certainly do our best to make sure that families understand the reason and the importance and how their therapists and their physicians will use these tools to help improve their care for their children. And so if the assessments are negative, they will not be repeated. If the assessment were to be screened positive, score positive, then the young person and or the parent would be asked to repeat that measure every 4 weeks until their TCHAT services are complete. So that way we can kind of really make sure that we're making progress. And if somehow the measures are not seeing a progress, then we can really drill down with the family about what other modalities or different things we need to do, as well as our team members that help with helping find referrals after, really understand what are the problems and challenges so we can really make sure we make the best type of referral to other services after our TCHAT services are complete. Next. And then again, this is just the trait roadmap for TCHAT. Most of these things, the expectation is for them to be ready at the start of the new school year. So our goal is for most of the referral dashboard and tracking processes be ready so that we can train our teams on that in that July timeframe, getting ready for August start of the school year. The family experience surveys, again, just like with CPAN, we are working with the internal evaluation team to potentially automate and send out surveys for families once their TCHAT services have been archived. So the idea is that we do want to obviously remain confidential, anonymous with these surveys. Families would potentially get the survey request after their services have been fully complete with TCHAT and in that archive stage. we're working on what the design needs to look like. So we'll have a better sense of the release date once all of those pieces of information get finalized. And now, I think this is the last slide. Yep. Questions?
Why don't we, Laura, why don't we go back to slide 19 real quick?
Slide 19. Got it.
Because I think we need an official action from the executive committee on this slide. And so Laurel is bringing to us this recommendation. I would say motion for us to approve this recommendation from the assessment work group. She has outlined why. And so do we have
A second.
a second? Dr. Podolitz and Karen Wagner. Very good. Any further discussion on this recommendation? Okay, if you take that slide down then for a second, just so I can see the whole executive committee. Okay, so we have a motion and a second. Any further discussion? Okay. Hearing none, all in favor?
David, I might just quickly note, this had the endorsement of the data management committee as well.
Very good.
So
Yeah.
it's I think it really will enhance our ability to kind of look at the outcomes of people in TChat.
Yeah, a lot of thought and process from multiple individuals, and Steve, I appreciate that comment that the data group has endorsed this. Any further discussion? Seeing none, all in favor signify by saying aye.
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 Opposed, nay. Did anyone abstain? All right, so we have unanimous approval. Any other questions or comments related to Dr. Williams' presentation?
Thank you, Laura. This was great. It's taken us a while to kind of come to a standard set of scales and measures. And I am so pleased that we are there, and it'll help immensely in all kinds of things. Thank you, Dr. Pliska, also for really working it through the data management group.
I appreciate that. I will say that our goal will be to train all of our clinicians. So we will be working on developing something that's both written and short videos so that we can make sure that all of our clinicians are understanding how to use these scales. We picked scales that we think are brief, that have data behind them that can be helpful, and that also we could use them in clinical care. So this is not completely about outcome measures for just the program as a whole, but really to make sure that we're guiding care in an appropriate way. And measurement-based care is really, honestly, the future is now. And so we want to make sure that we are really doing all that we can do, providing the best services to young people. But I do think that we will always want to keep that balance of making sure that if I'm going to ask a parent or a young person to fill something out, that our clinicians really understand how to use it and that they're talking about it when they're in their session with their young person and with their parents. I have myself experienced when people do measurement by case well in my own personal health care and when it's done poorly. And so, of course, we're going to all be guided by doing it in the way that's going to enhance and improve people's care. So I'm very excited for that. But we're going to be training our teams to really understand how to utilize these measures to the best effect.
Very good. Any other comments? All right. Well, thanks again, Dr. Williams. Looking at the agenda, I think we have maybe 30 minutes left of work today. And so unless somebody objects, I think we can just power through the next 30 minutes without stopping for lunch right now. And that way you'll have a longer break at the end. So why don't we then transition to the Higher Education Coordinating Board. They're going to have a presentation or discussion on the Mental Health Professionals Loan Repayment Program. And Ms. Serena, Maria, great to have you here.
Awesome. Thank you all for having me. I'm super excited to be here today to go over our Mental Health Professionals Loan Repayment Program. So a little background regarding this program. The purpose of the mental health professional, I'm sorry, you can go to the next slide. The purpose of this program is to encourage qualified mental health professionals to practice in a mental health professional shortage area and to provide mental health care services to recipients under different areas, different patient populations, primarily under the medical assistance program that was authorized by the Texas Human Resources Code in Chapter 32. and to enrollees under the CHIP program, also authorized by the Texas Health and Safety Code of Chapter 62. Now, this program was the recipient of major program expansions during the most recent legislative session, and I've gone over a couple of those items here. So one of those items was that this program eligibility was extended to providers working in state hospitals and local mental health authorities. Additionally, this program was expanded to licensed school psychologists this profession was added, and the service requirement was reduced from 5 to 3 years for new enrollees after September 1st of 2023. Additionally, this program funding received a significant increase. Our previous appropriation was about 1.3 million. We're now looking at $14 million per year. And these expansions have 100% worked in expanding access and these opportunities. We have seen a program application increase this year of 633%, which is incredible. If we can go to the next slide, I can go over the eligibility requirements. And so, of course, primarily one of the main eligibility requirements for this program is for providers to provide direct mental health services in a MIPSA to one of the following patient populations: to Medicaid recipients, to CHIP enrollees, to persons committed to a secure correctional facility owned or operated by or under contract with the Texas Juvenile Justice Department or the Texas Department of Criminal Justice, or by providing services to students in a school district which is located partially or completely in a MIPSA, or an open enrollment charter school located in a MIPSA, or a Title I school. Now, the student population is specific to the licensed specialist in school psychology. Additionally to providing services to an eligible patient population, providers must be an eligible practice specialty. So this program is open to psychiatrists, psychologists, advanced practice nurses who are board certified in psychiatric or mental health nursing, licensed professional counselors, licensed clinical social workers, licensed marriage and family therapists, licensed chemical dependency counselors, licensed specialists in school psychology. And lastly, in order to be eligible, applicants must have completed 1 year of qualifying service, be a U.S. citizen or a legal permanent resident, not be currently fulfilling another obligation to provide mental health services as a part of a scholarship agreement, a student loan agreement, or another student loan repayment program. And lastly, applicants must agree to provide 3 consecutive years of service at an eligible practice site. Next slide, please. So this slide is going to go over the different award amounts. So the following providers can receive the following award amounts over a 3-year period. Psychiatrists can receive up to $160,000. Psychologists, licensed clinical social workers, LPCs, LMFTs who have doctoral degrees, those populations can receive up to $80,000 a year. Over a 3-year period. Advanced practice nurses who are board certified can receive up to $60,000 over a 3-year period. Licensed clinical social workers, LPCs, LSSPs, and LMFTs who do not hold doctoral degrees can receive up to $40,000 over a 3-year period. Licensed chemical dependency counselors who hold an associate's degree can receive up to $10,000 over a 3-year period. Now, for any of these applicants, if their verified loan balance is less than the maximum award amounts, we will prorate their loan, their awards based off of those loan balances to be about 33% of their balance per year. Next slide, please. So I have some frequently asked questions. Of course, we'll have some time for other questions. But some of the frequently asked questions that we get is participation in the public service loan forgiveness disqualification for any of our loan repayment programs? And the answer is no. An applicant may participate in the public service loan forgiveness program while also participating in our programs. The reasoning for that is that it's not an actual agreement of service to participate in the public service loan forgiveness program. And some of our payments actually may count as a qualifying payment for PSLF. Additionally, a lot of the questions we get are these awards taxable? And no, these awards are not considered tax liable. And how are these funds awarded? Our funds are sent directly to the lender to be applied on the participant's account on their behalf. So we work directly with the student loan lenders. And these awards can go to federal loans or private loans or state loans. Of course, they must be an educational loan. And so we do look for that requirement. And those were kind of just our frequently asked questions. I also put our contact information. And then on the last slide is my personal email in case anyone has any questions. And so now I think we have some extra time. I can definitely take any questions if anyone has any.
I have a question to start off. Actually, if we put up the slides back and look at eligibility and help me think through for our HRIs, the people that they hire and how they are serving schools. They're serving school districts across the state of Texas, but they're employees of the HRIs. Would those individuals be eligible under the current guidelines?
So that's a good question. The way that statute is currently written for an applicant who is providing services at a school or a school district, they must be employed by the school district.
The way it's
So-
written right now.
Correct, the way it's currently written. So, short answer, and I was thinking about that and hearing the presentations. Unfortunately, it looks like the way it's written currently, no, those applicants would not be eligible.
But that could be something that could be adjusted during legislative session, just like it's been
Absolutely.
expanded last time
Absolutely.
to meet some of the workforce challenges our institutions are having. Okay, very good. All right, Steve Pliska?
One of the, if the Health Science Center, if our official address is located in a mental health shortage area, is the potential faculty member eligible regardless of the specific duties that they're doing? Or do you have to say that their actual practice location is in some certain place? Like all of Bear County, as I understand it, is considered a MIPSA, if that's the way to pronounce the acronym. But we've sometimes gotten advice that, well, no, unless you're working in downtown San Antonio, I think people are confusing the HIPSA with the MIPSA and so on. But just being on the faculty in a shortage area should suffice, should it not?
Correct, as long as they're providing service to an eligible patient population, they would be eligible.
And that would be defined, eligible patient population, what they're Medicare, Medicaid, low income.
Correct.
All right.
So long as they're in a MIPSA, which yes, if you look at the data from HRSA, like 99% of Texas is in a mental health professional shortage area. And so definitely we're confident that some of these rules, the way they're written, do offer an extended eligibility to a majority of practitioners. Of course, it's not perfect and there are a lot of areas. But as David mentioned, there's definitely opportunities for further expansion.
Because I think to David, Dr. Lakey's question is, well, they're not an employee of the school district, but they're an employee of the university, which is in the MIPSA area, so that should suffice.
So it depends because if you're working in your patient population is a school, you must be an LSSP. And so as an LSSP, you have to be employed by the school.
Well, that kind of, this I think is where all the confusion comes into. Is it the fact that you are an employee of the university in a MIPSA area, my zip code of the university is a MIPSA area, I'm eligible, period? Or does someone then come back and say, what exactly is this person doing? Is he downtown at the Robert B. Greene? Is he is he doing X, Y, and Z? That's where I think people get worried because they don't want to come back and say, oh, no, you're actually not eligible after all.
I see. So yes, it's a combination, right? So we look at patient population, we look at certification, and then we look at patient population. So it has to meet the combination of those.
If I could show you
And
this.
we've got a telephone number to call.
What?
So if we have a telephone.
Steve, I've been involved in this process before, and so the certification is like, yes, you work a certain number, you are in the shortage area, you certify how many hours you typically work, that you at least work so many hours a week, which we all can certify that, and all your people can. It's like 36, I think, if that's the same. And then that you serve a Medicaid population, that some of and not every patient has to be Medicaid. And so all of our people would apply if you have the health provider shortage area. I think the question that Dr. Lakey had about if the school thing would be applicable if you had an HRI that was not in the mental health provider shortage area, which could apply to some of our places. You're muted.
What makes applicants nervous is if we need to give them the absolute assurance that this was a forever deal, that nobody's going to come back and question what they're doing. If we move them from one clinic to another clinic, they don't qualify. So if you have those details, Sarah, that you could send me, or the website where it's listed, that'd be great.
Yeah, it's pretty clear on the website, and then they don't give you the money until they certify you.
Mm-hmm.
And so it's not like you would get the money and then you would say, oh no, I didn't meet these qualifications, and then send it back.
All right, good.
Maria left her telephone number and her email address. So it's right. All the information is there.
Let me lower my hand. Just a couple other people got hands up.
Can you hear us in the room?
Dr. Lakey, you guys are muted both places, so we can't hear anything going on there.
I'm going. I don't see it.
Now we can see one plate. We can hear the Texas Child Mental Health Care Consortium. We can't hear anybody.
I know, it's muted. I can't mute it.
I can't mute it either. It says we're on. Try and mute him. Can you hear it now?
He says he can unmute himself in the computer.
For me now?
We can.
All right. So sorry. Somehow something happened in the room and we got muted. Maria was given a great explanation about everything, and I think you didn't get to hear some of that. But Maria, let me go back to you to respond to some of those questions, and then I'll go to Dr. Ibrahim.
Yeah, of course. Definitely. We want to encourage as many participants as we can to apply because this is a wonderful opportunity. So we're happy to walk through any applicants through any questions that they may have, even through the application process. Certainly, we can put up the slide later about our contact information, and I'm happy to help in any way that we can.
All right. Very good. Hisham?
Yeah, I have a couple of questions. I may have missed it. Are psych nurses not included in the eligible groups?
Yes, advanced practice nurses are eligible if they're board certified in psychiatric or mental health.
Well, advanced practice providers, I get it. I'm talking about nurses.
So no, they must be APRNs. However, we do have another program that we're launching in the fall specific for nurses. And so they would be eligible for that program.
Yeah, because the hospitals would need that. I mean, probably not.
Most certainly is, especially with a lot of the initiatives right now the state is trying to do regarding nurse reduction or nurse shortage reduction. And so in response, we are launching a program this fall.
The other question, first of all, it's a great initiative, certainly appreciative of the increased funding. Expect that you probably gonna get a lot of applications. How would the application be prioritized? Is it first come, first served? Do you apply any criteria to prioritize areas over others?
Yeah, that's a good question. So we currently prioritize applications using a couple of different criteria. So the criteria we utilize is one, their MIPSA score, so which reflects the greatest need in the area. Additionally, we look at when the application came in, and there's certain other caps, so we can only accept up to 30% of certain providers. So we look at that, we look at funding, but the main criteria that we utilize is the MIPSA score, so the greatest need of the area.
Oh, so I'm asking this question because you've got multiple different groups that are engaged there, and that's not all geographic. Like when you say, for example, a state hospital, that could be in a non-geographic area that is not underserved. So that's why I'm trying to understand, how do you prioritize across categories that are not exactly the same?
Right. And so currently our prioritization model is listed in statute and administrative rules. So we follow that. And what is currently the practice is to prioritize the MIPSA score.
Okay. And the last question is, are these, once you are enrolled in that program, is that like forever and ever, or is that like a yearly reapplication, or do you have a period of time when you have to reapply?
Yeah, of course. That's a good question. So the initial application for enrollment, which is where we collect the majority of information, is collected just the first time upon the initial application. And then the year after that, after another completion of 12 months of service, we'll send out the application for payment, where the applicant basically just provides us with any updated information. We collect the employment verification to verify, of course, that they completed another year of service, and then we will issue payment.
Great, thank you.
Of course.
All right, very good. Octavio? Octavio, I can't hear you, my friend.
How about now?
I can now.
Okay,
Yes.
good. Technical difficulties everywhere. Anyway, great presentation. Love to hear about the percentage increase in number of applications. However, of the budgeted amount, how much has been expended, already awarded, and how far are we along to utilizing all these funds? Because one thing the legislature definitely wants us to see is full utilization since we asked for these funds. So how does that look?
Absolutely. And that is a fantastic question. I apologize. I did not come prepared with that information, but we could most certainly connect after this and see about getting that information.
Very good. I think that'd be really helpful for all of us.
Absolutely.
Any other questions? Seeing none, thank you again. Obviously, a lot of interest in this, and look forward to hearing more.
Awesome. Thank you.
And then just to obey my own rules of not putting anything in the chat, you may see that I put something in the chat just a little bit ago, and so I will read it out loud. I said, somehow we got muted. We can hear you. One moment, please. And so again, something happened and we are now back connected, but thank you for your patience. If we will, why don't we go to Baylor College of Medicine, have a presentation on the Safety A program. Dr. Pinachotti?
So Dr. Cincinnati, as far as I'm aware, was not going to do it today.
What's that? Okay. Oh, is it you?
No, she was going to, she's out of town. So I think she had asked Monet if she could do it next month.
All right. We will do that next time. No problem at all. Thank you very much. And then wanted to have as our last agenda item, I'm going to have Alex talk a little bit about the budget process. For those of you that we haven't met with yet, we are meeting with each HRI, having a one-on-one meeting, looking at expenditures in 24, how they can maybe be used in 25, and working on the budgets for the next biennium. I really appreciate the feedback and the time with each of the HRIs. And again, this is as I've started each meeting, I've started it saying that this is not a decision-making meeting. It's a meeting to understand your needs and your wants and opportunities so that we can build the budgets together. But Alex, let me turn it over to you, see if there's something that you'd like to end.
Thanks, Dr. Lakey. Like Dr. Lakey said, we are trying to assess your true needs going into the next session and kind of level set your budget to your experience so far in FY24. So, be thoughtful about the items that you're requesting in your FY25 rebudgeting, which you should be basing your FY26-27 preliminary budget on. And so we've had some good conversations, and most likely following your meeting, we'll have some kind of feedback and homework. And so we can work on that together, and just feel free to reach out to me if you've got any questions. But I think that's all I've got right now.
Thank you, Alex. And again, this is an important process. We need to get your feedback to make sure we use these dollars as efficiently as we can. There's times this time of the year where some institutions have dollars they don't have plans for, and there's other institutions that have needs. And so we try to move those dollars around to make sure that we meet the needs as best as we can in Texas. And again, this is a back and forth process to make sure we understand going into the next biennium what we think is reasonable related to the ask for the legislature. And we need to do that over the summer and get on pretty solid ground on those numbers come early, come August, because again, the goal will be to work with the legislature to before the session to try to get the requests built into the budget from the beginning. If you haven't been with us for the last several sessions, that has been an effective strategy for us because we're not a state agency, and so it works just a little bit differently. And so again, we appreciate the hard work from your teams, and again, look forward to seeing your budgets, meeting with you, and making sure we're all on the same page related to the approach for the next legislative session. All right. Any questions on that? Okay. I don't see any. I think that's the last item on the agenda. Is there anything else that we're supposed to talk to that's pertains to the agenda that we have before us? All right. With that, I think we are ready to adjourn. Again, I appreciate everyone's time, and I look forward to talking to you in our next meeting. Thank you.
Thank you all.
Thanks. Bye.
Thank you.
Blah.
I don't know if we can do it right now, or we have to wait till they have other things to do first, Dr. Wakefield.
I know, I was just